Good morning. I'm Candace DeMatteis, Policy Director for the Partnership to Fight Chronic Disease. Welcome, and thank you all for joining us today for the second segment of At What Cost, a series of discussions with leading experts who will share new research and their perspectives related to what we know now and what we can anticipate as the implementation of the Inflation Reduction Act, particularly related to Medicare drug coverage, continues to unfold. The series will examine concerns raised by patient groups and will review the early evidence relating to the IRA's impact on the issues that matter most to beneficiaries and patients alike. The IRA includes a lot of changes to Medicare's prescription drug program. While much of the attention has focused on drug pricing, the IRA also fundamentally changes how drugs are covered and who pays for what. Those changes will have significant impact on the affordability of coverage, the availability of choices among Part D and Medicare Advantage plans, and ultimately access to medicines. The announcement of Medicare prices for the first 10 drugs subject to Medicare pricing is fast approaching, and announcements about Medicare Part D base premiums came out just last week. Millions of Americans with chronic conditions, including diabetes, cancer, and high blood pressure, depend upon affordable access to prescription drugs. The drugs selected for price setting are not necessarily the most expensive, but their high usage among Medicare beneficiaries adds up for Medicare. And as a result, lowering spending will involve not just price, but demand. That means beneficiaries will likely face higher utilization management, like step therapy, prior authorization, and differences in where medicines are placed on formularies. Those actions limit access to medicines, impacting those who rely on them to manage their health. People relying on these medicines are braced for immediate impact, while others have serious concerns about what the future holds for access to today's medicines and needed treatments for unmet medical needs. There are already signs that the healthcare market is reacting. Today, we're going to learn more about health plans facing higher costs under the IRA's redesign of Medicare Part D. More than a few questions rise to the top, such as how are these changes and pressures on keeping premiums low and plans profitable affecting access to medicines under Part D and Medicare Advantage? What's at stake for patient access to the medicines they need, and what costs will they face? We'll hear from our expert guests, Kirsten Axelson and Michael Ward, on some of the work they're doing on this front and what Medicare beneficiaries should know. With that, let's dive right in. It's my pleasure to introduce you to our two expert guests. First, Kirsten Axelson is an advisor to the life sciences sector at DLA Piper. Kirsten has worked with biopharmaceutical and related companies for more than 20 years on business strategy and public affairs here in the US, as well as in the EU, China, and emerging markets. She focuses on reimbursement issues and other healthcare-related policy issues. She's an economist who works with healthcare clients on a range of issues, including Medicare reimbursement, payer contract negotiations, and designing innovative reimbursement contracts. She's also a Health Innovator Fellow at the Aspen Institute and a visiting scholar with the American Enterprise Institute. Michael Ward is Vice President of Public Policy and Government Relations at the Alliance for Aging Research. Michael oversees the Alliance's public policy and advocacy efforts. He has more than a decade's worth of experience advancing healthcare innovation through policy research, federal advocacy, and partnership development. Thank you both so much for joining us.
Thank you.
Great. Thanks, Michael. Kirsten, I'm going to start with you. There have been a number of announcements about changes in the Part D marketplace. For example, there's been announcements about plans actually leaving the Part D market. For example, last week, the National Hispanic Council on Aging released a report noting the loss of zero premium plans that are so critical for low-income subsidy beneficiaries. What are some of the trends that you're seeing in the market, and how does the IRA impact those trends with respect to Part D plans and Medicare drug coverage in general?
Thank you so much, and thanks for having me today for this important discussion. So, really since the inception of the Part D program, we have seen a lot of the enrollment shift over into the MAPD space, Medicare Advantage prescription drug. So that is an integrated managed care with the medical and hospital benefit as well as the drug benefit. And that's something that when the benefit started, there were far more people in the standalone plans, and low income people were in these standalone plans. By standalone, I mean only drugs, and then people got their hospital and doctor services on a fee for service basis. So with that migration, because the Medicare Advantage plans have the ability to use Medicare rebates to reduce their premium, we've been seeing more and more zero premium drug plans being offered from Medicare Advantage, which again further draws people into these plans. Those zero premium plans are averaged into the base premium, and in essence, the base premium in PDP has continued to stay very low. With the changes in which is a challenge for affordability and profitability of the standalone plan, unless they are very effectively moving people from the standalone plan into the more profitable Medicare Advantage plan if they have both. With the Inflation Reduction Act, the plans are being asked to take on far more risk, and particularly far more risk for low-income people and for people with serious health conditions because of the way the changes in the benefit design worked. The government previously had heavily subsidized people with serious conditions because they didn't want plans to use practices that discourage their enrollment, such as limited formularies. And many of those subsidies are going away. So I don't think it's surprising to any of us that there are PDPs exiting the market. We anticipated that they would have a harder time remaining profitable under the new benefit design structure. And it's not a surprise to many of us that the premiums are going up or the zero premium plans are going away. It is just going to be more difficult for a plan with only drug expenses to manage in the IRA. In addition to the subsidies going down, with the government stepping in to set prices, they're not going to be able to get the same rebate dollars from drug companies, which they had previously used to reduce their premiums to attract beneficiaries with these low premium offerings.
Thanks, Kirsten. That's a lot to unpack. So, Michael, I'm going to turn to you. As a leading voice on issues affecting older Americans, the Alliance for Aging Research does a lot of this work and really focuses in on affordability issues and access issues. And I know, in fact, the Alliance worked with Manette recently to publish a report that takes a closer look at some of these unintended consequences that Kirsten was talking about in terms of access and affordability. Can you tell us more about that report and some of the findings and policy recommendations about how we might move to alleviate some of those concerns?
Yeah, and I think what Kirsten mentioned really kind of sets it up nicely is that a lot of risk is being shifted to plans. For example, and this is like, all of the discussion, I think, when we talk about the IRA is all about price negotiation. We hear about that a lot in terms of the debate, but there are a lot of other provisions that kind of move responsibility around and kind of change both things for the better, and there may also be some unintended consequences from some other facets of the legislation. So to Kirsten's point, there is a shift going on, and it really ramps up next year. So in the catastrophic phase, the Part D benefits, so these are the beneficiaries that have the highest drug expenditures. Previously, last year, plans were responsible for only 15% of the spend in that catastrophic phase. And as we look towards next year, plans are actually going to be responsible for 60%. So this is a huge difference when you go from 15% to 60%, and it does change the incentives that plans have in terms of the levers they have to ensure that that they're maintaining their margins. And then this is also, and so what the Manette report does, it really digs into these challenges, as well as price negotiation. It takes a look at both of them as well, and takes a look at the impact that it'll have on potential beneficiary access. So, for example, when we're looking at the Part D redesign, there's also limited levers that plans have to kind of offset that. There's a restriction on how much beneficiary premiums can go up through 2029 in the Part D program, and so in discussions that we've had with plans, associations, in prior years, since the IRA has passed, they've said, there's really only so much we can do, that we are going to see increased utilization management. So not only prior authorization processes, but step therapy protocols, which, is so challenging for patients when they have to go through those steps in order to kind of get the medication that may be ultimately best for them, that their doctor knows, given their unique circumstances, may be best for them. And so I think it's going to be very interesting, especially now that, the plan bids were submitted, the formulary designs were submitted back in June, that we're actually going to see some of this start to, take place. And it's going to be interesting to see what takes root. So, and I think the other facet I'd want to note about that about the report is the price negotiation side, because there's also, it's not, the incentives aren't the same, but because Medicare is negotiating a price, it does create incentives for the pharmacy benefit managers and for plans to potentially, they have incentives to potentially change what they're prioritizing their formulary. For example, if Medicare is negotiating a price, then a plan may not be able to negotiate the same type and size of rebate that they have in the past. And so there may be an incentive for plans to prioritize in terms of where it's placed in the formulary, drugs that actually aren't selected for negotiation. And when we look at a situation like that, it would have a really negative impact, not only on access, but also it actually, especially if they have a plan that has a co-insurance, it actually, if PBMs and plans are doing this, then beneficiaries would see a negative impact just because they would be paying a higher percentage based on that higher amount for the non-drug that's not selected for negotiation. So the report goes into a number of suggestions that really are asked, all kind of circle around CMS being proactive in addressing these challenges, including, maybe should drugs selected for negotiation be exempt from some utilization management or formulary placement considerations? Should there be additional, in terms of process, insight into how many individuals are being subject to step therapy protocols, or having to file an appeals in Part D, and how quickly is that going? So there are 9 or 10 recommendations in that report, and I think it's a really great piece of work, and we're definitely looking to engage with CMS to see how many they might be able to put into practice.
So Michael, let me follow up with you. So if I understand what you're saying, you've negotiated the price, and some of these drugs, as we know, are super popular drugs, and some in the same therapeutic class. You've got the two leading clot busters, if you will, or clot prevention meds, and there are a lot of meds for diabetes and heart disease and these comorbid conditions. So if I understand what you're saying, you may actually see a PBM disfavor the drug that's been negotiated because they don't get the rebate, and favor drugs where they can get a higher rebate. And if I'm going to the pharmacy counter and I've got co-insurance, I'm paying 20, 30, 40% off the list price, so I don't even get the benefit of the negotiated price. Is that what you're saying? I just want to make sure I understand.
Yeah, that's exactly right. So it's basically that there are these market incentives that do exactly what you're talking about, Candace. So just due to the processes and incentives that PBMs and plans have that are so centered around these rebates that they receive, if they're not able to have the ability to negotiate the same size of rebate, it may change their incentives about where it is placed in the formulary, and where a drug is placed on formulary has a huge impact on how much a beneficiary pays out of pocket.
Thank you for clarifying that. Kirsten, I wanted to ask, we talked a little bit about base premiums, and they were announced, but as I understand it, it's related to what beneficiaries pay, but that's not, when you talk about premiums, we're thinking that's what I'm paying, but that's not what these base premiums were. And as I understand it, they were announced last week. They came in quite a bit higher on average than last year. I was curious what that means for what people can anticipate for premiums, Part D premiums, including the fact that the IRA includes inflation protections against premiums that mask some of those costs from beneficiaries, but obviously not from taxpayers ultimately. And then there was also a new demo that CMS announced for Part D plans designed to, again, to counter some of that increase in premiums. So can you help us understand exactly what's going on there, and what beneficiaries might be able to anticipate, and kind of what's at stake with respect to that, the access?
Yeah, so first of all, the base premium is not the premium that any individual will pay. It's a calculation weighted average, and depending on the plan you're in, there can be a different amount. What's what CMS released in the announcement of the premium stabilization program is that the base premium would have been much higher had they not had the voluntary stabilization program. In fact, the base premium is only 6% higher than it was last year, because of the stabilization program. So basically, the federal government saw the PDP market doing, I think, what many people thought it might do, which is seeing a very big increase in premiums, and stepped in, much as they have in other transition points, such as when the Part D market started, and ensured that there were, affordable options. Now we'll see if the stabilization program needs to go on beyond this year, or if the market is able to return to, some the levels of premiums that we've seen in prior years through market competition. So people will, depending on the plan someone is in, they could see a big increase, they could see very little increase, or they could see their drug plan going away, as we've seen many PDPs do announce that they're going to be exiting the market. I think something for us to all be watching, those of us who are particularly concerned about patient access, is how many PDPs go away. Where are the ones that go away? How many are left in certain marketplaces, especially rural areas, where there may be, a challenge to have access to an affordable Part D plan?
Well, thank you. That makes a lot of sense. Are there implications for the long-term viability as well for the Part D program as a standalone?
I mean, the thing is, they all play into each other, right? So yes, there needs to be some standalone benchmark plans in each region. And if, CMS were to have to continue, the federal government were to have to continue to stabilize, I mean, you're basically taking the money you're getting from some savings in one part of the program and putting it into the premiums. That seems like not a long-term sustainable solution. I think part of why there is interest in having a robust PDP market, one is preferences. Some people prefer to have a standalone drug plan and a fee-for-service Medicare. They don't want to have to be part of a managed care plan where they may not get access to the doctors and hospitals they want. But also, the Medicare Advantage costs the federal government more money than fee-for-service on a per beneficiary comparison. Even though the Medicare Advantage payments are set below the fee-for-service level, the Medicare Advantage plans are much better at diagnosing people, and that basically increases the risk score they get, and they get higher payments from the federal government. So again, this program that was intended to bring down costs and save the federal government money through drug price setting may be creating cost increases in other parts of Medicare.
Michael, one very touted part of the IRA and the change to drug coverage was the cap on out-of-pocket costs, and you mentioned that earlier. And that, as I understand it, kicks in 2025, and a lot of people are really excited about that. How does that affect affordability, both from the beneficiary side, but then also the plan side? And are we going to see that impact premium increases and plan choices going forward?
Yeah, I think that, certainly the out-of-pocket cap at $2,000 in 2025 is a huge win. important to note, just in terms of future years, that the $2,000 cap is tied to growth in Part D spending. So we may see that cap grow, in future years, likely to grow. So just in terms of expectation setting, I think that's an important piece of the puzzle. Now, in terms of I think the challenge that we kind of get to is around choice, because in rural areas and areas that are generally underserved, where the population is underserved generally by the healthcare system, which be maybe socioeconomic, it may be an equity consideration. And so I think it's important to make sure there is appropriate plan choice. That way people aren't forced into plans that are, that really don't offer a robust benefit or have very stringent requirements in terms of step therapy and whatnot that really are harmful. And so, writ large, I know that we see that, that beneficiaries are very, they do not like to change their plan from year to year. Once they are in Medicare, they tend to stick with it. Over 90% of beneficiaries stick with their current plan. And so we are going to see a ton of changes to the market this year to the benefit that really have a really, it's going to make it more important than ever for beneficiaries to change, to potentially consider changing, at least evaluating their plan, because many beneficiaries may have selected their plan prior because it was the cheapest in terms of their drug costs. That tends to be what beneficiaries are most sensitive to. The cap, that may change, their plan benefit may change, there may be competitor plans that change. And so that's going to be very important, and it's going to be extremely important to understand kind of these changes, these utilization management changes, to make sure that, to understand if the drugs that they're taking or are likely to take are subject to and how stringent those requirements are, because often whenever you switch plans, you may have to, if you had to go through step therapy before, if your new plan also requires step therapy, you may have to start at the beginning and take drugs that you already know don't work for you. Sometimes you can file an appeal and get that requirement lifted, but it's it's an arduous process. And so so I think just writ large, it's very important for everyone to kind of be thinking about these changes this year and make sure that there's choice, and that people are assessing what their choices are as we head into open enrollment starting in October 15th.
Thank you for that, Michael. I did want to let the audience know we will have audience Q&A, and there is a Q&A button at the bottom of your screen. So please feel free to send in your questions. Kirsten, you mentioned, and Michael, I'd love for you to weigh in on this as well, is that some of these changes to the standalone Part D plans may encourage people, and I know, Kirsten, you've talked about too, that some standalone Part D plans may be a feeder into Medicare Advantage plans. What are the implications for that, given overall viability? You mentioned, Kirsten, that Medicare Advantage is more expensive for taxpayers, but it also offers more coordinated care, more benefits. I'm just wondering what the pro and cons are from a beneficiary's perspective, but then also a larger economic perspective. Michael, why don't we start with you with a beneficiary perspective there?
And sorry, I think I cut out just for a second. So could you repeat just the end of that question, Candace? I apologize.
Sure, no worries. I was wondering from a beneficiary or patient perspective, what the shift toward Medicare Advantage means. Is it, I'm sure positive, negative? What should beneficiaries be looking for if they, just given the viability of standalone Part D plans and what it means for people who prefer that fee-for-service Medicare and Part D standalone?
Yeah, it's I can see both sides of the coin here. I mean, I know that just it can be helpful. I think just conceptually from a healthcare perspective and risk sharing perspective for to think about Medicare Advantage as MAPD plans as a good thing, because if you are responsible for the medical cost of a beneficiary, then you may be less you may be less likely to think about some of these applying some of these barriers, because you know that if these barriers may result in outcomes that have an additional hospitalization or something else that ends up being very expensive for the plan. So there's certainly advantages there, but to your point, Candace, I mean there are, as we've kind of been talking about, there are areas that have limited plan choice, and or maybe subject to strict requirements in terms of the formulary. And so, whenever there's more competition, among plans, I think that's generally, a good thing, because then they kind of have to compete on the merits, on the access, and then, and then beneficiaries will choose kind of the plans that have the best benefit design and parameters for them. And people kind of go to where they'll hopefully shop and move with their feet. So I think that's really the facet that we want to see, because I think the demo shows is that CMS is very concerned about the long-term kind of viability of these standalone PDP plans. And so they're taking a proactive step to make sure that that those plans can be viable in the future. I will take a brief aside and say that I think that this PDP, the challenges that we're seeing with standalone PDPs, is very easy to anticipate based on what's been going on, and just based on the IRA's kind of setup, the way that the parameters were set up. And I think these changes that we're talking about on the patient side to to utilization management, they're also very predictable, right? Just given the higher responsibility that plans have. And I know that we've been talking to CMS, other patients have been talking to CMS, at least over the last year plus, about these coming changes, why we're worried about it. And it's been I think the sense we've gotten is a very wait and see approach, like we don't have the data yet. And so, ideally, it would have been nice to see CMS take a proactive approach to the challenges that patients are likely to face, just like they are doing on the standalone PDP side.
No, that's helpful. I think in the latest guidance from CMS, they did use those words, "We're going to wait and see." So, a little frustrating, but at least it's on their radar. Kirsten, what about from your perspective? What about on the marketplace side of, what these changes mean long-term for standalone PDPs and choice? And I'm also, not to get political, but it's curious that some of the biggest critics of Medicare Advantage in general, voted for some of these changes that may end up pushing more people into Medicare Advantage.
I think perhaps the effect of changes and incentives may not have been fully thought out in terms of the long-term impact, right? And also there was, again, thinking about the politics, it's wildly popular to control drug prices. And so maybe the calculus was more swung towards that rather than thinking about the long-term effects on the Medicare Advantage market. Certainly as more people go into Medicare Advantage and the government's costs rise, you see MedPAC's been discussing payment rates in Medicare Advantage. If I were a betting person, I would imagine that will be a continued focus of policymakers, is thinking about Medicare Advantage payment rates, which, as Michael mentioned, integrated care makes a lot of sense for a lot of reasons, and extra benefits makes a lot of sense for a lot of reasons. And considering how pharmacy spend affects medical spend, can definitely be a benefit in terms of care coordination. That said, not every treatment saves money. Living longer costs money. It is just a fact. And we have to just accept that if we're going to want to have a society where we live longer, it's going to cost us more money. If there was a disease that had no treatment and now it does, and the person previously died, there's no cost offset there. And we're seeing that more and more. And so, if we have a bar where spending more money on drugs or preventive care or nutrition needs to be fully offset by a cost savings, we're just not going to be able to see that. And having an aging and healthy population is a cost to our society. It's also a benefit to our society, but a lot of the benefit does not go into this calculation. So, and again, thinking about the market, if the PDPs do continue to decline and go away, and Medicare Advantage continues to grow, again, I anticipate probably more scrutiny on Medicare Advantage payment rates, more scrutiny on total cost of care delivery, which will lead to more rationing of care, more utilization management. I mean, that's something, if I were a patient advocate, I would really be thinking about how do we advocate for clinically appropriate utilization management, because that has not been a focus of the formulary review, right? Like, is a drug on or off formulary is the requirement, not is the utilization management onerous in such a way that it's really getting people to leave their therapy entirely.
Oh, all great points. We did get a question from the audience too on the impact. You talked about access to care and changes in the dynamics, and cancer is a leading cause of death and a pretty frightening diagnosis despite the significant advances that we've seen. So can you talk a bit about what you see as the impact on research? It's it's a lot of significant unmet medical need in cancer, rare cancers in particular, but all types of cancers, as well as other therapeutic areas as well. So, Michael, do you mind talking a little bit about that? That might have been included in some of the Annette report that you talked about as well. It's those unintended.
Yeah, I think the challenge that we're seeing, I mean, and this kind of extends beyond the provisions we've talked today, but there are other provisions in the law, in the IRA, including the difference in exemption period, 9 years for kind of the pills that you typically pick up at a pharmacy counter versus the larger molecule drugs, that are typically administered in a physician's office or in an infusion center. So, in a space where, in like cancer, where you have drugs in both spaces, you have treatments that are both in the Part D space that are typically in tablet form, and you have others that are infused. What this really does is it changes the dynamics where it kind of puts the finger on the scale of pushing towards drugs that are infused. And I think the perspective that the Alliance has is that we want to make sure that the most promising therapeutic delivery method is the one that is sought after, rather than it being driven by payment incentives, right? And so I think that's a challenge, and especially since when we're talking about this favoring products that are physician administered, that when we're talking about older adults, that also has a huge impact, just because as you're older, you end up having often more mobility challenges. It may be difficult. You may have to rely on a family member or and maybe an Uber in some cases to get to an infusion center. And so there are just like real practical life value to having therapeutics that you don't have to travel to. So I think that and that's really a difference in the political climate that we see now versus 20 plus years ago. Whenever there's a large bill, a huge bill like the IRA, like the Affordable Care Act, there is always a need for technical fixes, just because there's always something that doesn't quite operate just as you wanted it to, or there's an impact that wasn't necessarily foreseen, just because there's a lot of people talking, especially at the end of a bill when something comes together, and things kind of so much can change just based on one single word, like designation versus an indication. And so there used to be a market where you could do these technical fixes. The political climate has changed, and that's much more difficult now. But I know that we're hopeful that as the law is implemented, as some of these impacts become evident, that there will be a bipartisan approach to making some tweaks to ensure that that as we're talking about research, whether it be cancer or other areas, that it really is driven by the data, by the science, kind of rather than by some of these incentives that may not truly be the best for what's coming out long term.
That makes sense. Kirsten, what about in terms of the pharmaceutical and research portfolios? Are there changes afoot? And we've heard anecdotal things and people warning about this happening. Is it happening? Is there evidence of these types of decisions already being made?
You do hear a lot of announcements about certain programs being canceled. And that's not surprising. And because also remember, there is so much risk in early development. There's so much unknown risk. Why would you lean into a known risk by investing in a small molecule medicine that's likely to have large sales in the Medicare population? And that is what I hear when I talk to my friends who are investors is, so much of this is based on faith and science. And do you believe in the management company? And then you add in this other thing that is like, oh, well, there's another black cloud hanging over this drug. That one just became more unappealing to me. And there's a ton of other drugs that are more appealing. And then there's also the post-market development. A lot of cancer drugs have development programs well past the 7-year mark, which is when they could potentially be selected for price setting. Some of them may still continue. Look, there's drug development programs for drugs that are generic, but a lot of them won't because there won't be still profitability remaining in doing that development program. And if you have the choice of putting your money into a development program where the government's setting the price and the revenue just fell by, 20, 30, 40%, versus putting it into another drug, you will be more likely to put your money into another drug that isn't subject to the price controls. So I'm anticipating we're going to see a lot more strategy in drug development focused on avoiding the penalizing aspects of the Inflation Reduction Act, which takes strategy away from pursuing the best available science, which is, again, a concern I have with the way this law is designed and being implemented.
Thank you for explaining that. Last question to you both is, what issues are missing in your perspective or not getting enough attention in discussions about the IRA, the Medicare drug price negotiation program, and why should they get more attention? Michael, do you mind if we start with you?
Yeah, I think a lot of the issues that we talked about today would fall into that bucket for me. But and I think the chief among them is just around, what the implications are of how these financial incentives for plans, how it may change beneficiary access. And so it's not something that's like prescribed in the law. It's like, okay, we're going to make plans responsible for 60%. And so, it's up for us that have been in the healthcare world to say, well, this is like the implication of that long term and on patients. And so, but so much of, I think so much of the oxygen in the room and around the discussion of the IRA has been around one facet of the law. There are many good aspects, not only the $2,000 cap, but the insulin cap, as well as eliminating vaccine copays, expanding the eligibility for the low income subsidy program. But there are that is being paid for in many ways, in terms of how it was in the CBO score, by making some of these trade-offs. And so there is a role and a real way for CMS, for the Medicare program, to take a proactive role to set expectations clearly. And if they do that, then it can blunt inappropriate utilization management, where it is overzealous, where in cases where it may result in, in irrevocable loss of function or loss of quality of life. But we haven't yet seen CMS do that and provide that clarity about what constitutes a reasonable reason to change the formulary. It can't just be for because we're responsible for these increased costs now. So that's what I think that's really what we're looking for, and what we need other groups to come alongside is to say that there are changes that are legislative and there are things that are regulatory need to be changed. And so let's not overlook the piece that CMS has and the role they have here to make sure that this is implemented in a way that beneficiaries are not harmed, due to these unintended consequences.
No, great point. There's a lot of discretion at CMS, and really important that patient communities, consumers, and others weigh in to make sure that any harm is minimized, and that it has the patient-centered focus to these regulations and implementation. Kirsten, how about you? Anything that you think should get more attention and should be on the radar that maybe isn't getting the attention it deserves?
Well, I second everything Michael said. I think we've put way more attention on the price negotiations, the price setting. And I always say this law affects every single drug in America, because it either affects the drugs that are directly price set, they're affected by the reimbursement changes, they're affected because a competitor is price set, they're affected because the commercial market just got more competitive, because the plans are losing money in the Medicare market. Like, every single drug in the US is affected by this law. I think the point that again, and Michael brought it up, what is this going to mean for access? The out-of-pocket cap is a great thing for patients, but it's going to mean that plans no longer have a financial tool to steer utilization. So what kinds of utilization management, what kinds of non-financial tools are we going to see? And what does that mean? I think people think prior authorization, it just means that some paperwork has to be filed and people take their drug. Very often in prior authorization, people never end up getting their drug. They walk away. They don't end up being able to get through the process. Or step therapy, they walk away because they, for whatever reason. We know there's lots of research on why people walk away. So we can't think about step therapy and prior authorization as being just a paperwork process. It's a process that means people don't get treated. And I think we need to be putting more focus on what do these utilization management techniques do in terms of people actually getting the care they need, and are there ways to do it that are more beneficial to patient care? To Michael's point, if you change a plan, is there not some longitudinal way to carry your record through, or an attestation process that would say, no, I already tried and failed on another drug? How can we make we have to live in a world of utilization management. It is appropriate, but how can we make it more streamlined for patients so that once they've actually taken those steps, it counts towards their future paperwork burden?
Thank you for that. I know there are many efforts and even bills in Congress addressing the Safe Step Act and others, and a lot of interest in the physician and patient community around prior authorization and streamlining that process. Obviously, that will become increasingly important as implementation moves forward. Thank you both so much for this great conversation, and thank you all to our audience members for joining us today. And we hope you'll tune in again for the future segments of our series, At What Cost? Next Wednesday, August 15th, we will be releasing a new set of research that takes a closer look at some of the impacts of the IRA on innovation across several disease states, including cancer. We got that question today. Experts agree that the IRA will lead to fewer new medicines in the future, but those estimates don't include losses from the important gains from finding new indications that Kirsten and Michael talked about from already approved FDA approved medicines. We worked with Humanity on this issue, and we'll have one of their lead researchers join us next week to walk through the specific findings and case studies for existing drugs for rare diseases, cancers, mental illnesses, diabetes, cardiovascular disease, and autoimmune diseases, to take a look at kind of what if the IRA were in place, and what would that have meant to new indications, new developments in these very important therapeutic areas. We'll be joined by patient community leaders from Cancer Support Community, Schizophrenia and Psychosis Action Network, and the Autoimmune Association to cover some key questions about which diseases are at risk of innovation losses and why. What are some of the harms to patient health, and what's driving those risks, and what can be done to lessen the potential fallout? Please join us next week and continue following along at #MoreThanAList. Thank you all so much, and thank you again to our experts.